Cabin pressure. All right, great. Okay, so you've all identified the site very well. And the clue in there was obviously the fact that this is an aeroplane window. So this is a young child on an aeroplane who's experiencing ear pain. And I don't know if you know this, but actually children are much more prone to experiencing ear pain on flights than adults are, because their eustachian tubes that connects their ear to their nasopharynx is very short. So they really struggle to equalize pressure in their inner ear. So that you can see the clue there is the child is clutching on her ears, and the second clue is that the child is on an aeroplane. So that is what's obviously causing pain in that instance. All right, next picture. All right, what do you think is going on there? This is an easy one. What's happened to this poor kid? Where is the pain? Yep. Good. Bike accident, knee graze. Okay, that was a very, very easy one. That's quite obvious, isn't it? All right, next one. Okay, anybody know where the site of pain is in this case? Right, looks like the abdomen. Okay, great, great. Okay, anybody know what the cause might be? A little bit trickier. It could be anywhere. Okay. All right, what's very typical here is you can obviously see the child's got a scrunched face, so he's clearly in pain. He's clutching his abdomen and he's drawing his legs up to his abdomen, which is very typical behavior for children with abdominal pain. Obviously not as obvious as the child with a knee graze, and you're right, there are numerous causes of abdominal pain. Until we've examined him, we're not really going to know what the source of the pain is, but he's got a very classical picture or behavior of a child with abdominal pain. All right. Next one. Okay, where do you think the source of pain is in this kid? Right, chest pain, yeah. Chest. Right. Okay, heart, chest, yeah. Okay, anybody else got any other ideas as the source of this pain? There's a clue in the child's particular expression on his face. Okay, somebody's saying, yeah, maybe this is the throat. I think it's a little bit lower than the throat. Anxiety, yeah, I suppose. Okay, this is actually a child with heartburn. So you can see he's clutching his chest, but you can also see he's got that expression of like nausea going on there. Right, last pain. Okay, what do you think is happening to this poor kid? Who is the source of pain there? Procedural pain. Very good, Tracy. All right. Injection, doctors. Yep. All right. So the clue there, obviously, you can see this poor kid. It looks like he's being held down on an examining couch. You can see the medical professionals hovering around his bed. They've got gloves on. I know the picture's a bit blurred, but one of them looks like they might have a specimen bottle or something. So this poor kid is obviously experiencing procedural pain. All right. So seeing physical pain, usually the site is quite obvious, as you can see there. The source is often clear. The behavior is usually typical. If the child is old enough, he can verbalize it. My ears are sore, my tummy is sore. And generally speaking, when we know where the site is, when the behavior is obvious, it's usually, and we can find a cause, it's generally easy to treat. And usually this kind of seen physical pain resolves quite quickly with treatment or prevention in the case of procedural pain of the underlying cause. Sometimes we get away without providing analgesia if you can actually remove the cause quickly enough. We don't provide major analgesia for every knee graze. And most of the time, this kind of physical pain is resolved through the use of simple analgesia. So when we speak about simple analgesia in pain medicine or palliative care, we're usually referring to basic non-opioids such as paracetamol and non-steroidals, and maybe in combination with an opioid as well. All right, but a very important caveat is, as simple as this actually looks, some people actually miss seeing pain. And it's still true to this day that in children, pain is under-recognized and under-treated. You know, just the example of the child on the aeroplane, it really actually surprises me today how few parents actually are aware of how painful that ear pain can be in children, and how parents don't prepare their child to fly. You know, if they've got a cold, you should decongest that child. You should give them a dose of Panado before they fly. If we are going to be doing procedures in children, we should prevent and we should manage that procedural pain. But still to this day, procedural pain in children remains undertreated. And sometimes people think, oh, children are not actually going to experience that pain. And so a very useful thing that I was taught early on in my career, which I think is very useful advice. If the pathology is going to be painful for an adult, it will be painful. And actually, in most instances, it is usually more painful for the child. So while I'm going to be focusing on unseen pain, I just wanted to remind everybody that even seen pain that is obvious and can easily be treated is often underlooked. And we must please be pain warriors and pain advocates and make sure that seen pain is treated in children. I'm now going to turn to the more difficult pain, which is the unseen pain. And this is actually from a blog in the Cambridge Children's Hospital. And this particular blog is written by a 15-year-old boy who's got Ehlers-Danlos syndrome, which is a syndrome that is associated with lax ligaments and hypermobile joints and a lot of dislocations. And these children often have quite severe pain and functional limitations. And he wrote this blog because he kept being asked at school, like, what's wrong with you? And so I love this book, My Hidden Illness by Ali. And you can see he's drawn two kids that look exactly the same. And that has been his experience of his unseen pain. Everybody thinks, oh, you don't look distressed. You look pretty focused. You're smiling. I don't see you have any problem moving and you don't look uncomfortable. But actually, under that facade is a child who's feeling sick, who's feeling drowsy, who's feeling exhausted, who's feeling very anxious, who's dizzy, and actually has joint pain. So sometimes what people are experiencing is not always what we can see or what we can actually acknowledge. And this is the more difficult type of pain to see in children. So what I thought I would do is actually to take you through two case studies that actually made quite an important impact on my life and taught me something about unseen pain in children. So the first is a 6-year-old little boy who had a rare inborn error of metabolism. I'll tell you a little bit more about that later, called glutaric aciduria type 1. And he presented with severe muscle wasting, with severe spasms and feeding issues. He had a septic thumb, and he also had pressure sores on his feet and hip. And he was one of 3 children. His mom had unfortunately died a year ago. And unfortunately, the dad, because he was working, was not able to care for him, and he was admitted into a children's home. Unfortunately, something happened at the children's home, and he ended up being rushed to Red Cross Hospital with a blocked feeding tube and in a state of dehydration. And Red Cross resuscitated him and got him back to a baseline, and then basically sent him to our children's hospice at the time, while they were waiting to find a new placement for him. And here's a picture of him just after we had admitted him to the children's hospice. So you can see a child who obviously looks quite sick. He doesn't appear to be very focused, and he certainly doesn't look very interactive at all. I actually thought he had quite severe mental retardation when I first met him. And then it was quite obvious during his hospice stay that this was an irritable boy. He was especially irritable when he was fed and also during episodes of severe spasming. He was also unable to tolerate boluses. The moment you try to give him too much feeds through his peg, he just went into spasms and looked very, very uncomfortable. So we were forced to put him onto a continuous feeding tube. And on observing him closer, I actually worked out that the reason he had a septic thumb is because this child was biting his thumb because of severe pain. So we started him on a low-dose morphine, and we also added some gabapentin for the neuroirritability and the neuropathic pain. And we also started him on music therapy because we realized that he really lit up when somebody was playing music. We also managed to get the dad to visit more often. We kind of thought that he was missing his father. And he started to smile and he started to laugh again. And then because he managed his pain well, he actually was able then to tolerate bolus feeds, and he started to gain weight. We then sent him back to Red Cross for a checkup, and the referring neurologist said to me, "What have you done to this boy? He is a different child." And he has a picture of him afterwards. Completely different kid, smiling and enjoying life. And that to me was a real wake-up call. I think this child probably had a lot of unaddressed pain that somebody hadn't picked up. And what I was seeing as mental retardation was actually pain. This was a child that was drawn, anxious, and depressed, and in unmanaged pain. And managing his pain made a huge difference to his quality of life. So just to tell you a little bit more about what was actually going on, what was causing the pain in this child. So alpha-glutaric aciduria is a very rare condition. It's basically an inherited autosomal recessive condition where there's a particular enzyme called glutaryl-CoA dehydrogenase that is either absent or present in very small amounts. And because of that enzyme deficiency, abnormal organic acids collect in the brain. And these basically you can see in the middle of the slide there, these are neurotoxic, and they actually damage the brain and lead to things like subdural hematomas. And there's this characteristic batwing sign that you see on the MRI scan in these children. And these organic acids actually, unfortunately, have a predilection for the basal ganglia. And those are part of the brain that actually is responsible for controlling movement. And that also explains why these children are very dystonic and have episodes of spasming, because of the brain damage from the accumulation of these organic acids. They also have big heads, so they're often macrocephalic, and often because of the issue with breaking down protein, they fail to thrive. And then what happens to these children is if they actually develop a cold or a flu, they go into actually a metabolic crisis, which leads to further breakdown of their muscles, which explains why his muscles were wasted. And actually, if this is not recognized or non-treated and you don't get them out of a metabolic crisis, they can actually start fitting and then can go into coma and can even die during a crisis. If you do, it's obviously a very difficult thing to diagnose. It's not on top of everybody's lists, but if you do actually diagnose it, you can actually manage this condition by providing a protein-restricted diet. And they also are specific formula that are specifically designed for children with glutaric acid urea. And you also provide them with carnitine. If you happen to diagnose it early, the best case scenario is diagnosing it on newborn screening. Then you actually prevent the brain damage. But if, as in our case, it's diagnosed late, unfortunately, the damage that has already occurred in that brain is not reversible. But if you start providing the right formula, then you actually prevent further ongoing neurological damage. But if you don't diagnose it at all, then unfortunately this condition can actually be life-threatening, and children can die during a dystonic crisis. But I think the thing that, even though our neurologists clinched this rare diagnosis, the thing that they had not diagnosed was the fact that this child was in pain. He was neuroirritable, and he had something called visceral hyperalgesia. So viscera means organ, hyper means excessive, and algesia means pain. And basically what has been described is in children with neuroirritability or neurological impairment, they actually are super sensitive to gastric stimuli that in the normal population would not cause any pain. So that was basically explaining the reason why he wasn't able to tolerate his bolus feeds. And once we actually managed his abdominal pain and his neuroirritability, he was able to tolerate feeds and gain weight. So I think, it's also very important to understand the pathophysiology of this pain. All right, but I think it would be amiss of me to think that all of his pain was just physical. Yes, his physical pain was due to his underlying inherited condition. It was due to his neuroirritability. It was due to his spasms. It was due to what was happening in his abdomen. But this little boy also had psychological pain. He'd been separated from his father. His mom had died a year ago. And who's to say that he wasn't depressed? I think depression is another symptom that is totally underdiagnosed in children. And the literature describes children as young as 3 experiencing depression. He also had social pain. His mother had died and he'd been separated from his father and siblings. And he also had spiritual pain. He was no longer connected with his family, and he experienced a lot of joy from music that was obviously removed when he was in a children's home. And he was also obviously, from a cultural perspective, being looked after in a setting that was not part of his cultural upbringing. So we cannot only look at physical pain, we need to be able to address all the domains of total pain at the same time, which explains his dramatic response. It was not just due to my colleagues tell me I love gabapentin, which I do, and I call it magic fairy dust. And it was not just due to the magic fairy dust, it was because we had a holistic approach to him. So that change that the neurologists were seeing, not just because of the magic that we did with our drugs, it was also because of the nurturing environment that he was in, the music therapist that was involved, and the fact that we got his dad and his little brother and sister back into the hospice. All right, so that's an example of hidden pain in a non-verbal child. I'm now going to just share briefly with you a case of hidden pain in a verbal child. So this was a 13-year-old girl who had had quite bad Henoch-Schönlein-Purpura 2 years ago. So Henoch-Schönlein-Purpura, I'll tell you a little bit more about it later, but it's basically an autoimmune type of vasculitis, often precipitated by a viral infection. And this was a complicated illness for her, and they needed to manage it with prednisone and dapsone, and usually it resolves, and usually you only get it once, but she unfortunately had the kind with it actually relapses. And a year after her first presentation, she had another illness, also presenting with the characteristic rash. But she also had some funny symptoms that people couldn't work out. And sometimes when people can't work out what's going on with patients, they send them to psychiatrists. And the strange symptoms that she was experiencing was fainting and this funny leg numbness. She also unfortunately came from a background that was complicated. There were complicated psychosocial issues. She was unfortunately being bullied at school, and there were complex family dynamics at home. And she was complaining of chronic muscle weakness. She was extremely tired. She was struggling to walk because of the numbness that she was feeling. She actually needed a crutch, and even at one stage was in a wheelchair. And she got sent to me by a rheumatologist who said, I really don't know what's going on with this child. Please, can you help? I can't find any source of pain. And so she came to us, and what we did for the first few visits was actually just to listen to her story. And she'd actually written a poem, and with her permission, I would like to share this poem with you. And I think it's really a good portrayal of actually how deeply this pain had influenced her. I am so angry, I want to scream, as I taste the saltiness of my tears forming a stream. I am so angry, I want to scream. My legs are numb and I feel dumb. My fingers are stiff and I can't manage a whiff. I wish I could just throw myself off a cliff. At school, people look at me with suspicion and reprieve. Maybe it's fear that I may fall, collapse, or give them a germ. Tick-tock, tick-tock, there goes the freak. Teachers don't see me. They do a good job to ignore me. I try to explain it's me, just meek and mild me. It's still me. Tick-tock, tick-tock, there goes the freak. My doctors argue in front of me, can't seem to answer any questions about me. It's mental, they say. Time to bring in psychology. Your body's stiff, abdomen tender. Try and walk if you can remember. Pop the meds if your pain grows in temper. Tick-tock, tick-tock, there goes the freak. As I sit on the couch, the good doctor taking her notes. So how are you feeling? If only I can go on bended knees. Doctor, won't you help me, please? My parents sit by my bedside, doting over me, as I lie in pain, feeling that I am going insane. Frustrated by my agony, I appreciate their support in me. Can't they just let me be in all my misery? I'm angry. I want to scream. How can this be? It isn't me. I have been bullied and spawned, all because of something unknown. I am pale, tired, and withdrawn. I just don't have the energy anymore. HSP, you have won. Now let me be done. You have taken away my dignity. What more do you want from me? So you can hear in this expression of this child extreme anger and frustration, not understanding the source of her pain and not getting any reprieve. So what I did in this instance was just to actually read a little bit more about Henoch-Schönlein-Purpura to try and work out what on earth was going on. Why would this disease that this child had 2 years ago still be causing her so much pain? And traditionally, if you know anything about Henoch-Schönlein-Purpura, it doesn't normally manifest as a neurological disease. It usually involves little blood vessels, it affects the kidneys, it affects the joints, but there's not much that's written about nervous system involvement. So I decided to read a little bit more deeply. And basically what I found is, it's important to remember that the nerves are supplied by blood vessels. And what happens in Hemlock-Schönlein purpura is that sometimes the vasculitis affects the blood vessels that affect the nerves. And that's why she had a neuropathy. So that's why she was experiencing pain in her lower limbs. And that's why they were feeling numb and why she was really struggling to walk. But she also had neuroplastic pain. So because she had been in chronic pain for so long, her brain was really needing to be rewired and reset. And her brain was actually generating pain because she was so preoccupied with it. And she was so fearful of being in chronic pain forever that her brain was also generating an element of pain. So she really needed a multimodal approach. So she unfortunately ended up having what I call a failed psych admission because nobody could understand what was going on with her. They unfortunately sent her to a psychiatric facility for evaluation. And it was a horrible experience for her because her phone was taken away and she felt like she was being locked away. And we actually ended that psych admission prematurely because it was really not the right place to assess her pain. And actually what really helped with her was just telling her story. And I think writing that poem was extremely cathartic for her. Because she actually had objective signs of a neuropathy, we actually also treated her with gabapentin. Interestingly, she'd had nerve conduction studies done that were negative, but that does not preclude a neuropathy because sometimes the nerve conduction studies don't look for the right pathways. We also provided her parents with a lot of psychosocial support. I wrote numerous letters to the teachers and the principal to try and address the bullying that was happening. And we also incorporated her into an adolescent chronic pain support group where she got to meet other children and young people that were experiencing pain. So she realized that she wasn't a freak, that there were other people that this had also happened to. And after many months of engagement, she actually started to walk without support and she gradually improved. All right, so my top tips for seeing unseen pain based on these cases is really the most important tip, I think, is about really listening, because a lot of her narrative was about feeling unheard. Listen to the patient and the caregiver. They're the ones who've been through this nightmare. They're the ones who can give you clues and information to what is actually happening. I think one also has to become very aware of what pain-related behaviors are, and there's a lot of information around this in the literature, but also be aware of some non-typical behaviors. So it's actually described in some CPs that sometimes they laugh when experiencing pain. And the best person to tell you about this is the actual mother of the child. They know how their child responds when in pain. And I think what I learned from both of these cases was also to think physiologically, to go and look at what the underlying source of the pain was. But I think also use common sense. And also very important, understand neuroplasticity. There's unfortunately not enough time to go into it today, but I think it's a very important concept to understand in chronic pain. So I just thought I would share with you, and I'm sure many of you are already aware of these pain scales, but there are quite a lot of pain scales that have been developed to look specifically for the more difficult pains in children. And we all probably know the FLAC score. The problem with the FLAC score is it was actually developed for the evaluation of children with post-operative pain that were normal, and it wasn't really validated for children that had neurological impairment. So in 2006, it was actually revised to include special considerations for children who have neurocognitive impairment. So everything that is in red in the scale are the different things that you need to look at for children that have neurocognitive impairment. Also, obviously recognizing that a lot of these children already have increased tone because of the underlying neurological disorder. And so you need to take that into consideration and you need to make adjustments accordingly. And these slides will be shared with you, and you can see there's a nice link there to the revised FLAC score. And then there's another tool, which is actually more designed with the family or the mother in mind. And this is called the Pediatric Pain Profile. It's quite a long assessment, and it's really needs to be done, I think the best way to use the pediatric pain profile is to get a group of moms together who've got children with neurological impairment, needing to monitor pain, and actually take them through this book. Basically, the book asks the mom to do a little bit of a pain history. It asks the mom to observe the child in different types of pain and to record how the child responds to different pain. A lot of these moms have worked out what helps to manage that pain and to document that as well. And then basically the pediatric pain profile assists the parent to establish a certain baseline, and then with engagement with their treating provider, they come up with various non-pharmacological and pharmacological interventions, and then basically continue to monitor it. And it's a great book because then it's kind of serves as like a pain diary, and then the parent can bring it in the next time the child is being seen in the clinic, and they can actually make adjustments to the child's both pharmacological and non-pharmacological management plans. It's quite detailed, and for some parents it might be a bit too complicated, but I think the idea of the caregiver leading the pain management process is really what this document exemplifies. And then our friends Patrick McGrath and Alan Finley developed another tool called the Non-Communicating Child's Pain Checklist that was revised in 2004. And basically what I really like about this is it's a lot more simple compared to the pediatric pain profile. It's quite similar in some ways to the FLAC, but it is actually a little bit broader, and it adds things like physiological signs as well as the impact of pain on eating and sleeping. So it's a bit quicker to do than the pediatric pain profile, but it's a little bit more expansive than the revised FLAC. And it's useful in children from the ages of 3 to 18, and a score greater than 7 on this scale is indicative of pain. So another very useful one-pager to use in a difficult population. And then, of course, my favorite pain assessment tool is, we've called it the PatchSA color tool, but it's actually originally based on the Earline to Body scale. And this is obviously for use in neurologically normal children who are able to draw. And basically what we do is we give them this diagram of their bodies, front and back, and we ask them to create a color code, mild pain, moderate pain, and severe pain, and then to map out the corresponding parts of their body where they are experiencing mild, moderate, and severe pain according to their color code that they have established. The nice thing about this is it acts as a bit of an object of transference, because often children find it very difficult to talk about their bodies and where they're experiencing pain. But if they can put it on a piece of paper, it makes it a lot easier to talk about. And the nice thing that I like about this is, particularly for ongoing pain management, is every time the child comes back for an appointment, you don't show them the one that they did last time. You give them a completely new tool, and they do it again, and then you can actually see progress of the pain, the chronic pain management as the months go by. So another very useful thing. And then there's this great website that I highly recommend. When I first saw it, I thought, oh, this is in Holland. No, it's not. It's in Ontario in Canada. And it's the website for a kids rehabilitation hospital. The link is in the bottom there as well. But they basically got a whole toolbox. It's aimed at parents again, and it's a knowledge translation type website. And they've got a whole lot of these researched evidence-based tools for assessing and managing pain in children with disabilities. A really good free resource that's freely available. Yeah, so just to conclude, just because you can't see it doesn't mean it's not there. Listen and observe, encourage narrative. And when patients are telling their stories, be non-judgmental and be curious. Perform an impeccable assessment. Look for clues. That septic thumb in that first child, I never thought it was a sign of pain until I saw him biting his thumb during a dystonic episode. So it was a real lesson in really doing a top-to-toe assessment of that child. Try and understand the pathogenesis of the pain, because that really helps you to manage it. And I think in everything that we do in medicine, remain humble and open to learning. Be led by the child. The main team is not us. It's not the medical professionals. It's the caregiver and the family. Listen to them. They're the one that is up with this child at 3 o'clock in the morning. And when managing pain, today we just focused more on assessment, especially these kind of more complicated unseen pains need a multimodal approach. that addresses total pain, not just the physical components, the psychological, the emotional, and the spiritual. And on that note, I'm going to hand over to Joan Marston to address spiritual pain. Thank you, everybody.
Thank you, Michelle, for a great presentation. And I'm just going to share my screen. Sue, could you allow me to share, please? It says someone else is sharing.
Michelle, can you take this down?
I have taken it down, yeah.
Is that okay? Can
Yeah, we can
everyone
see
see
you.
my screen? I'm just going to open it up. Right. So thanks so much, Michelle. And really so much of what you said was about spiritual suffering and spiritual pain as well. And it really shows that we can't look at the child in bits. We have to look at the child, the adolescent, the adult as a whole person. And so while today we're looking at just really bits of the person, it is part of a whole picture. And so to start with, I'd like to think about the meaning of spirituality and of spirit. And I love this quote by Teilhard de Chardin, who says, "We are not human beings having a spiritual experience. We are spiritual beings having a human experience." And I'd love to know what you think about that, if you agree or don't agree. And you know what we do, words matter, and the way we say them matters as well. And so if we talk about body, mind, and spirit, what have we done in medicine and palliative care? Focus very much on the body, a bit more on the mind, and the spirit gets, oh, that's the job of the pastor, the priest, the imam, the rabbi. So we don't need to know much about that. But actually, if we talk about having being spiritual beings, it is every bit as important as the clinical part as well. And if we think that the goal of palliative care is around prevention and relief of suffering, then when we are learning and when we are teaching and when we're doing research, we should do just as much on spiritual care, spiritual suffering, spiritual assessment, as we do on all the other elements of palliative care. And so spiritual counselors and chaplains are really essential members of palliative care teams. Not, oh, we'll call in their minister, we'll call in their rabbi, because believe me, some religious leaders are very bad at looking after children who have serious conditions. And we have to make sure that spiritual assessment and care is part of every care plan, including advanced care plans as well. And so to start with, I'd just like to do a bit of refreshment about what is spirituality and religion, and to set the scene about how we need to be, because if we aren't comfortable in our spirituality, we're not going to be comfortable in dealing with the spirituality of children. We're going to look at signs of spiritual suffering, the seen and the unseen. And often it's not so much that we can't see it, it's that we won't see it. We have our own business that we haven't dealt with our spiritual life, with past problems. And because of that, we're uncomfortable dealing with spiritual suffering in children. And so we'd rather not see it. We'll look at some steps we can take in the process, and then some of the tools that we can use. But because we can't sort of identify, if I were to ask you, what does spirit look like? Where is spirit? What color is spirit? I doubt if you'd be able to tell me. Little children can. If you ask them, they will draw you something. It might look a bit spooky, but they will do something. And we need, and we are the tools. We are the most important tool when we're doing this assessment. And we need the history documents. We need history for guidance. We need to be aware of our own spirituality, because we're all spiritual beings, and our own spiritual history as well. And of course, when we're working with children, we need all those communication skills that we learn about. We need to be able to listen to them. We need to be able to get down to their level, to play with them, to observe, and for them to accept us. And for that, we need to be that caring, that accepting, that loving presence, so that if they have a question about spirituality, like these little ones who came to me. 4 and 5, we'd had a child who'd died in Sunflower House. We had prepared them for the dying of the child. And because they were all from a Christian culture, we talked about heaven, going to Jesus, but we never actually used the word dead. And so they came to me, these 3 little ones, having discussed it themselves, and asked, what does it mean to be dead, Sister Joan? And I think they felt comfortable with me, but also we were outside in nature, and that had a chance to play, all things that make a child comfortable. So the definition that is most universally accepted, and I think it's an excellent definition, it's one you can make up your own tool from. And it talks about spirituality as being dynamic. It's intrinsic, it's part of us, we're all spiritual. And it's about the seeking for meaning and purpose and transcendence, and about relationships. It's about connecting to ourselves, to our family, to community, to society, to nature, and to the significant or sacred. And so we can actually make our own tool, taking all those parts of this definition, and we express it through our beliefs and our values, our traditions and our culture and our practices. And this comes, of course, from Christina Puchalski and those that she works with, and I'll speak more about that later. And just to get this out of the way, religion is about a belief in a supernatural being or beings. It's about a system. It's a system that we set up. And so if you're a Baptist, if you're Jewish, if you are a Muslim, we'll have different systems of faith and worship. It has externally a communal aspect. People come together. They might take part in rituals. It might be simple. It might be more complex. But people are getting together to share their same beliefs and their spirituality. And so spirituality and religion, up till a few years ago, we were taught they were 2 totally separate things. But of course, we know they're not, that we often express our spirituality through our religion. And Dr. Anne Merriman, who so sadly passed away this year, said, spirituality is the journey. And she actually said religion is the mode of transport. But of course, some people are not religious, and they may have another way to express their spirituality through nature, through music, through playing golf. And so I've changed it to religion may be the mode of transport. So spirituality is the bigger, religion can enclose part of it. And the essence of spirituality is relationships and connections. And so when we are disconnected from what is important, that can cause spiritual suffering. So we are connected when we're whole. We are connected to what gives meaning and purpose in our lives. And what we see as meaning and purpose is really very different to what a child or an adolescent might see. The child's meaning in life and purpose is to get up and play, to find their friends, to go to school, to have a hug. And positive connections are so important. And so if we're feeling, or if we feel this child is disconnected, often just taking them outside into the garden, into nature, can help them feel connected to something greater than they are. And this word transcendence, it really comes from the Latin meaning beyond and to climb beyond, to experience something that is beyond our normal experiences, or to do or hear something that is beyond our ordinary limitations. So that is a very unknown and very powerful part of spirituality, and children are intrinsically spiritual. And so because every child is unique and different, and because children are developing, the way they will see what is important when they are 3 is going to be very different to what they see as important, perhaps when they're 10 and when they're 17 or 18. They have a natural connection to something greater than they are. They can wonder at Harry Potter or at the stars. They have this natural awe at things that are greater than they are and unusual. And so when we're working with children, when we're assessing spiritual suffering and pain, we need to use different approaches, different tools, and different ways of communicating with that child. As they develop, just as they develop physically and emotionally, they can show different spiritual characteristics. So in those very young ages, what really is important to them is to be close to someone, to be held, to be loved, and motor relationships. So playing with items, playing with people, playing with pets, playing with others. And they love to use transitional objects like toys. And that's where things like my lovely Eeyore puppet come in very handy with little ones. As they get older, they often have these magical thinking and animistic thinking. And so rituals, playing certain games that they play, certain activities that they do are very important. And of course, as they get older, they start to think, almost unfortunately, the way that we do. They get their fears, the guilt, the and so as we approach, we have into a wardrobe. They're very comfortable with Harry Potter. With fairy tales and stories that we'd say. But just like us, they have a need for meaning and purpose. They want to know that they mean something. They have things that have great meaning to them, whether it's a toy when they're younger, whether it's their best friend, whether it's their ability to do something like sing or play sport. And they're spiritual seekers, but they don't always have the language. And so we're going to be looking at that unseen spiritual suffering. And in fact, suffering is the beginning of seeking. And we have to then say that when they can't talk, when they can't express it, they can tell us through the way they use play, the way they use art and poetry. And we need to speak to them in language they can understand. So you won't say to a 4-year-old, what gives meaning to your life? You will say to a 4-year-old, what do you like to do? What's fun? What do you like to eat? Who's your favorite person? And so we have to be creative in assessing them and expressing our own responses. And I love Mark Bartel's work, which a lot of people are using. And he said that we have these basic human needs: love, faith, hope, integrity, virtue, and beauty. And within these are found the whole breadth of human spirituality. And so when we're spiritually comfortable, when we're not suffering, we are well connected. We are comfortable in our connections. But the minute that we get disconnected from these, then the suffering begins. So it might just in the beginning be a disconnection with one aspect. But with so many of the children that we see, they are disconnected from virtually everything. And that is when deep spiritual suffering occurs. And so the indications of spiritual suffering might be questioning, like in this children's letters to God. Dear God, here's a poem. I love you because you give me what I need to live. But I wish you would tell me why you made it so we have to die. And there are many indications of spiritual suffering. It could be a withdrawing, it could be the questioning. They can't take part and they don't want to take part in things that they've enjoyed before. They might feel that they've been abandoned. We see so many of these children separated. And in fact, the formal healthcare service and often the formal pediatric healthcare service, which has a unit, which has hospital beds, disassociates these children from what makes them feel safe and comfortable. And we need to be aware of that. And so we learn from our children, and I'm going to share some stories. And I love this. Sister Frances Dominica, one of the great early pioneers of children's palliative care, set up Helen House, the world's first unit for children's hospice, said, the children are our teachers. We are the pupils. It is a masterclass. So remember that. You can learn everything in the books, but actually the children will teach us. So my first teacher in palliative care was a beautiful little girl. Her name was Bella, and she got involved with us. When she was 20 months old, her mom had died. We had very little history, in fact. In fact, the staff they'd gone to collect other children from the children's home who were our patients, and she came with them. She came to our daycare program. She appeared to be very developmentally delayed in every way. It seemed as though she couldn't walk. She wasn't expressing emotion. She didn't make eye contact. She didn't interact with anyone, the other staff or the children. And her only comfort appeared to be from food. In fact, she looked like a little Buddha. I can still see her so clearly. And what happened is one day she was sitting there where they placed her, she sat. We thought she couldn't move. We thought she wouldn't move. And her carer had walked out, and I happened to walk past, and I saw this little Buddha get up, go to where there was a plate of biscuits, help herself to two, go back to where she was sitting, sat down just the way she was sitting, ate the two biscuits. Of course, there was the evidence, the crumbs around her. And then she just appeared to be the way she had been before. So we knew immediately she could walk, she could reason. The biscuits are over there, I'm over here. If I want to eat them, I've got to go and get them and eat them. And she could come out and into her emotions. And so what we used, and here I'm not going to go into detail because we were able to actually develop a wonderful plan for her, is I sat her down, and because a ball is an amazing connector. And if I were to say one thing that you need in connection in spiritual care, it's a ball. Different sizes for different children and different ways to connect, to use them, was just throwing it to her, rolling it to her, and she just sat there, ignored it, picked it up, rolled it to her again. And after a while, she thought, there's a mad woman there throwing this ball at me, and she's not going to stop until I do something. And she started pushing it back. And eventually, within about an hour, we got a little giggle. It was a lovely, deep chuckle that came out of her. And it was a way, having seen what was happening, we realized this child had deep suffering. And so we went to getting her history, because that was our big mistake, was not having a full history. And that's what we need when we're assessing spiritual suffering. Always take a full history. She lived with her mom in a little room. Her mom had loved her, looked after her. You could see that. Very poor, but it was quiet. Very few visitors. When her mom died, no other family wanted her taken out of there, put into a children's home with other children. Noise, activity, new people. She was too young to understand that her mother had gone and wasn't coming back again. And so she withdrew, and she suffered silently from those disconnections. And so when that child is really reserved, like Michelle said, we thought this child was intellectually disabled, but actually this child wasn't at all. There was everything going on inside her, but she was suffering so much. So what we need to do is find out what's important to the child. That's where the history is important. Assess what connections there were that have become disconnected, and find a way to reconnect. It can be a very, very long process. It can happen very quickly. As I say, within an hour, she had relaxed. She was playing. She even laughed. And from that time on, she progressed really well. She was disconnected from love, from her mother, from her stability, from her home, from the security that she had known. And all that remained for her connections were food, and we believe play. And that also was a connection to her mother who loved her. So when we go to take the history, it can either be from the older child or from the parent when the child is very young, or it can be for both of them together. But the important thing is to make that area comfortable for the child, to connect whatever way you do it, whether it's through talking, through playing, through laughing, through bubbles or puppets or balls or art or music. Ask that screening question. Ask, and I'll go into that just now. And if they want to continue to discuss issues around spiritual care and spirituality. And then we can take a history. We can use tools as guidance, but we don't sit there with a form and say, you know, what church do you belong to? What gives meaning, and fill it in. Do it as a discussion. You can record it with permission, and then you can transcribe it. But it's better to do it just as a conversation, and then to do the writing down later on. And once you've got the history, and once you've identified what it is that is causing the spiritual suffering, then you've got to do a full assessment, preferably with someone who has knowledge if you are not trained. If you've had the training, and we'll talk about that just now, then you can perhaps do it yourself. And then the planning and implementation come maybe in another lecture, but not for this particular one. So the screening is about, is your religion or spirituality important to you or your child? Do you belong to a faith community? Would you like to talk about it? And if they don't want to do it, we don't push it. And there are various tools that we can use to take a history. So I like using the FICA or the FICA and the HOPE tools. FICA is very simple: faith, importance, community, and how we're going to address that care. And there's a lot of literature about the FICA tool coming from the George Washington Institute for Spirituality and Healthcare, where you can also get training in spiritual assessment and care. A very simple tool to use. It has a very broad reach. As faith is about belief and culture and what is important and what gives meaning. And then I like the hope questions as well. I think it's very comprehensive. It's, again, simple to use. What's your source of hope or meaning or comfort or strength? What gives you peace? What do you love? What do you feel connected to? O is for the organized religion, and then P for personal spirituality and practices. What do you do? Maybe your spirituality is bird watching. Maybe your spirituality is very linked to your religion. Maybe it's going for a walk with your friends. What is important to you? What gives your spirit strength? And the E, the effect on your medical care and end-of-life issues. So if there's anything that we need to know about, are there rituals? Are there people we should call? Are there beliefs that are going to maybe be in contrast to what is proposed by the medical professionals? I'm not going to go into the beliefs, although I know that it is quite usually used, but it's another very good tool. It's not one that I'm particularly comfortable using. So what I want to say is, when you're using a tool, use one that you're comfortable with and that fits with the child or the family you're assessing. So I want to tell you about Susan. She was 16. She had an astrocytoma, diagnosed at 10, progressive. With all her treatment, she'd lost her hair, she lost her sight in both eyes. She had progressive muscular weakness and significant weight gain because she was on steroids, and she had these anger outbursts, especially at her older sister, who was healthy, who was good at school, because she was very intelligent. But with what had happened with her astrocytoma, she couldn't go to school, she couldn't dance, she couldn't play the piano, all things that she did. And we were sitting together, and she was very quiet. And so I said, Susan, shall we play some music? And what would you like to listen to? And she wanted to listen to what was a pretty modern pop song in those days. And she stood up and she did one of the most moving, sensuous dancers that I have ever seen. And I get quite choked up when I think about it, because this was a 16-year-old. She was an adolescent. She was a sexual being, but nobody saw that. And her suffering was linked to her sexuality and wanting what every other girl wanted. She wanted to look pretty. She wanted to go to dances. She wanted to have a boyfriend. And she couldn't express it because people would think, what is this girl with no hair? And she can't see, and she's overweight, and she can't walk. You know, they're going to laugh at her. But she did this exquisite dance. And I feel incredibly, incredibly privileged that I was able to watch it. And once she'd done that dance, we were able to talk about it and bring her friends in, and who then took her to, in a wheelchair, took her to the dances, made all the boys talk to her, did her nails, put on a lovely wig, made sure that she had a pretty dress on. And just because we chose that bit of music that she felt that she could express to. And what I also use with older children, adolescents, I use the who, why, what questions. And I say to them, ask me all the who's, all the whys, all the whats. And once you've done that, then we can start addressing that. And it's a very simple tool to use, and they enjoy doing that. And then we look at what had given her life meaning and purpose. And these things, the normal things, they weren't abnormal. Family, friends, having fun, church, school, music. And she was disconnected from everything. And so we had to look at ways of reconnecting her to those things that we could. We could to music, we could to, in fact, we managed to reconnect her to everything. But unless she expresses it, unless we are listening, unless we are that accepting presence, they won't accept it. And what about those children? This is a quote from Elizabeth Kubler-Ross's Wheel of Life, where she talks about how do geese know when to fly to the sun? And how do some people know when they're going to die? There's a voice within us, and there's a voice within children as well. And sometimes they can't express it because if a child says, I think I'm going to die, what do we say? Oh, no, we don't want to talk about that. No, you're going to feel much better tomorrow. Stemmy was 3. He was really sick. He was lying there on a bed, and he was on oxygen. And I came in to take another child out, and he put out his arms. I picked him up. He wanted to go to the door, took him to the door. He pointed at my car. And so I said, do you want to go in the car? And everyone was saying, oh, Joan, you can't do that. He's going to die. And I thought, well, he's dying anyway. So if he wants to go in the car, let's take him. So we did. And for 2 days, he indicated that he wanted to go to his favorite places, his favorite people. And then he wanted to go out at night, and he pointed at the stars and he said, Stemby's star, which is his legacy. And then he died. And so how did he know? He was a child of very few words. So there is this, if we're talking about transcendence, that children know. Godfrey loved to draw, and he was actually seen to be improving. And he told us, I'm going to die. And we said, oh, we sort of really didn't take it very seriously until he started giving us pictures of modes of transport and drawing things that he loved in bright colors, like sunflower houses covered in sunflowers, but he drew it and he painted it red because red was his favorite color. And then in some of his pictures, we saw he had, just in pencil, with all these bright colors, he put planes and rockets and helicopters. And when I asked him, I said, you've drawn those beautifully, but why they're only in pencil? I know I'm going to heaven, but I don't know how I'll get there. And he was inside, he was suffering because he was afraid he wouldn't go to heaven because he didn't know how to get there. And so through his art, he was able to express his suffering, and that suffering became seen. Our wonderful chaplain came to see him, and he did beautifully after that, and he died. We didn't think he was going to. He said, I'm going to die, and he did die. So many questions that we have to answer with children. Am I going to die? What does it mean to be dead? Why me? What did I do? What will happen to my body Are you going to burn it? Are the worms going to eat it? Are you going to put me under the ground? Why me? And who will remember me? And our Sunflower Wall, our Wall of Remembrance at Sunflower House, is actually a response to a promise that we made to these children that we will always remember them. And unfortunately, I can't talk about the family today. I've focused on the children, but of course, their suffering is immense. And whatever we do, we have to deal with the suffering of the family as well. So what we do is we give the gift of accompaniment. We're there for them. We're there, we're sensitive, we're caring, we're open to their questions, we're open to their suffering, we're opening to be there in whatever way they need. And you can get training. So the SPEC training, which happens twice a year, and they give lots of bursaries for the online part of the training. And I would really encourage you to do it if you're interested in that. And I would also ask that you understand yourself. What is your spiritual awareness? Are you comfortable with your own spirituality? And very importantly, what do we do to strengthen and develop our own spirituality and knowledge? Because the more we do that, the more we can help these children and families. So namaste. The spirit in me greets the spirit in you. Thank you. And these are just a few references for you.
Wow. All I can say is thank you to Michelle and Joan. What wonderfully insightful topics and talks. And I know I've learned a lot from the both of you today. And I see a lot of children at work. And I am taking away a lot of the tools and the information that you've given us. I really am inspired. And I hope that our guests and our participants who are joining us have learned a lot from you both. It was really inspiring. So thank you very much to you both. I did see one or two chats and questions in the chat, but I think some people have answered them. There was one from a colleague who had asked about local injections that have been given in, she had asked local injections that are given to children in dentistry. And her question was, local anesthesia is well used by dentists before the injection. Why not before any injection for children? And that was her question. Anyone wants to take that? Michelle?
Yeah, sure, of course. I think obviously we've got Emla cream that can be used. A lot of people will say, oh, we don't have time to apply it. But actually, if you actually do local anesthesia properly, you're more likely to draw that blood or put up that drip. And it really should become part of standard practice in pediatrics. And it works beautifully. And yeah, highly recommend it.
Yeah, so we also practice a lot of procedural pain methods at work as well, and it's quite important. EMLA is one of the things that we advocate for, and a lot of distraction techniques, and for the smaller babies, it's the breastfeeding, it's the sucrose as well that we give the kids, so it's quite helpful. So I do recommend the EMLA. It's very out there as well. The next question was from Susan, and I think Melissa did mention. She says she's not a medical professional, so maybe it's obvious to most here, but she was wondering whether pain changes as her child grows and gets older, and if they have a chronic condition causing chronic pain.
That's a very important, very, very relevant question. So when you actually, if we had more time to do pain assessment, there are different pain behaviors that are explained in terms of children of different ages, and people often actually use neurodevelopment as an excuse to believe that certain children didn't feel pain. And it was only in the 80s when people actually started to realize that newborns felt pain. A lot of people thought that newborns didn't feel pain. And they rationalized it by explaining, oh, their brains are incompletely myelinized. They don't have the capacity for memory, so therefore they can't remember pain. And that's not true. Newborns have got everything that they need to feel pain. And in fact, the pain is more than felt a whole lot of neuronal rewiring happens if you have unmanaged pain in the newborn period. And studies have shown that with unmanaged pain in the newborn period actually lowers pain thresholds in children for the rest of their lives. So if you don't treat newborn pain, you can actually affect that child's pain perception for the rest of their lives. So yeah, you know, the brain does, there are definitely different stages of pain behaviors that we need to learn about when assessing pain in children.
Thank you, Michelle. The next one was from Palisa. She had asked, how often is play therapy used in these spaces, especially at hospices and hospitals? And because as Joan Marston mentioned that children were playing outside and they were comfortable to communicate. I actually did a talk on legacy and meaning making. What I found it quite interesting in my literature review for that topic was that the American Academy of Pediatrics actually recommends that every hospital employs a child life therapist who actually is supposed to engage our children in play therapy and distraction therapies whilst in hospital to make their stay a better stay, and engaging with them and addressing their pain. It's so much that they can do, but unfortunately we don't have access to these people. That is why we have to be innovative in our way of managing the pain, and I'm sure Joan has some insights as well onto that as well.
Yes, thanks so much for the question, and Sam as well. We have occupational therapy students, the fourth years, who come to Sunflower House, and they are absolutely essential to the well-being of our children. But I think we can all learn basic, simple play activities. My goodness, we can remember that far back, can't we? As I've said, even if you have something as simple as a ball, what I sometimes do is I take a ball, and depending on the child, I put questions on the ball and we throw to each other. And it might be questions like, what makes you happy? Who's your favorite person? What's your favorite thing to do? Just to get them to relax and to start telling you things. So as you throw it, you say, where your thumb lands, we're going to answer that question. Then I'll answer it and they'll answer it as well. And so we can all use certain tools that you feel comfortable with. I have this very tatty Eeyore puppet, but it's a very comfortable puppet. It's got a nice face, soft face. He's soft. I actually found it in Uganda at like a jumble sale. And he was very torn and tatty, but I loved his face. So the tools that you use as well when you're doing your own simple play things, make sure that they're not frightening, because I can tell you some toys that you see in the shops are very frightening. But play therapy, art therapy, music therapy, dance therapy. You know, often these children, their bodies have changed. They feel uncomfortable, and getting them to dance and to move actually makes them more comfortable in their bodies. And so I've done lots of dancing with children as well. So we need to use all of these therapies to help the children relax and to get contact again with themselves, with their own bodies, and to make them feel like children again.
Thank you for that, Joan. I think those are quite nice ideas. I think I'm going to take that to my pediatric ward. I'm going to get the rainbow color ball and start that with the kids and see how I can get some information from them. A comment from Tsepiso. She says taking a proper history is really vital. It helps to clear misconceptions and give a clear understanding of an individual, as spirituality is deep. I truly hear you, Tsepiso. I appreciate this comment. It's very, very true, because there are things that we do miss, and we always tell our medical students, as well as the interns, history taking gives you at least 80% of what your diagnosis is. So it's very important that you take a proper history, looking at it from a different perspective than putting your thoughts and your feelings into it. Michelle, I'm not sure if you want to comment on anything. I'm just looking if there's
I
any
just
more.
wanted to say, you know, I also spent some time in the States observing in various children's hospitals. And I think as South Africans, we mustn't feel, oh, because we don't have child life specialists or fancy professionals, that we can't do stuff, you know. And to me, the most accessible and the most available professionals are our nurses, you know. And I
Yes.
think our nurses can provide valuable support when it comes to procedural pain control. We can teach them how to do the distracting. And I think another very important thing that I wanted to say is please don't involve mothers in holding their children down for procedures. And that's so wrong, you know. And I think we need to learn how to teach nurses to hold children properly physically so that the procedure is done well. But I think nurses are a valuable resource, and many of them do this naturally. And I think just because we don't have child practitioners, I think there are things that we can do in
Yes.
South Africa.
Yeah.
I agree. I think we can work with what we have and who we have, and we need to empower the people that we have to say we can really make a difference. Yeah, it is really, nurses are there and they are the cornerstone and they're actually with the patient more. And I totally agree with you, Michelle. We should not allow the mum to be there when you're doing any procedure. An example was when today at the clinic, they were actually putting an NG tube on a 4-month-old. And no one told the mum, please, you can leave. And I happened to walk past and she was cringing and she was sitting there and she had her head turned the other way. And I'm like, Mum, please can you leave so we can do this properly? You don't have to be there to watch your child. So she left, and I think that helped her, because for a mum, her child's already suffering and now we don't want them to see that we're adding to it. That is why we need to try our utmost best to try to not make that child suffer in the eyes of the mum. Okay. Another comment, and if the child is old enough, getting them to blow bubbles. Yes, blowing bubbles is a great distraction technique. Therapy, Lisa. And then Melissa says, but at the same time, don't ask parents to leave the room. It makes them scared. So you have to give them that option. Do they want to stay? Do they want to go? And I think we need to respect either. Because some parents want to stay and some parents don't want to be there. And if they want to be there, they can be there. But you just need, I think it's also important to explain what you're doing to them or their child so they know exactly how it is.
Yeah.
Okay.
And I'd just like to say as well, Sam, that Lisa Lucani has mentioned bubbles, and that's something I love to use as well. Bubbles, crayons, a ball, all things that you need to have in your bag when you go to a child.
Teddy bears mean the world to them, and carrying a teddy bear around or giving it to them as part of them makes them feel so much loved and comforted. I think a teddy bear for a child every time they come to hospital is very important. Are there any more comments or questions from our participants? We have 5 minutes left. Okay. I see that Tracy had put in the link for the website survey. I do would recommend that people do participate in our survey so we can see how our webinar is going, what we can change in the future, what we need to add. We would really like your suggestions as well. There's a comment from Bobby. She says, as a mother, I sat with my children and gave them my finger to bite when the procedure was painful. Bobby, thank you for sharing that. I really appreciate it. I cannot imagine how hard that was for you, but you were their strength and you gave them that strength and courage. Thank you. Lindia says it made her curious to learn more. Yes, curiosity is out there, and I hope that we have planted a seed in you guys to take back with you, to sprout, to grow, to go to higher lengths, to advocate for children's palliative care, as well as to ensure that our children are adequately managed with respect to their pain, the seen and unseen pain, as well as their spirituality. Okay, so we have put the link again. I'd really appreciate if you guys could please comment or participate in the survey. And I would like to thank our speakers for taking the time and sharing their insights and their knowledge with us today. It has been quite interesting. It's very informative. And I can see from the comments, lots of our participants has really appreciated this talk. They are going away with some knowledge, with tools, with information to go back and manage their children. And yeah, and I hope to see you guys more. We're going to have many more webinars as we go along, and we will be posting them soon for you guys and relevant topics. I mean, should you have some topics that you would like to ask us to present, that you think it's a burning topic that you need information as well, you can email it to us and tell us exactly, and we can see how we can help you as well. So thank you, Joan. Thank you, Michelle. I really appreciate that. To our team in the background, Sue Boucher, Tracy Rollins, Busi Nkosi, you guys have been instrumental with planting our webinar series, posting it on social media, getting all the students to join us. It's been awesome. Yes, and there's a QR code as well. If you want to scan and do the survey, it's easier to do the link. You guys can feel free to do that as well.
And thank you, Sam, for keeping us all in order.
Oh, you're most welcome. I think Tracy was the timekeeper, so it all went well. All right, thank you, everybody. We hope to see you soon.
Thank you. Thank you.
Cheers, everybody.